Oh, hello then, and welcome to this webinar today. I'm Francis Seeley from GlobalNet 21 and Info Voices, and this is one of the many webinars we do where we look at some of the issues that face us, not only nationally, but locally and globally as well. And today we're looking at the area of health and how you can deliver health in a different way, in a collaborative way. Instead of working through single institutions, people come together and work collectively to achieve a common goal. And we've got Alyson McGregor with us today from Altogether Better. We're pleased that you're here, Alyson, which is great. And she's going to describe the work that they do in developing this collaborative way of working. But first of all, I'm going to ask you the question we ask everyone, Alyson, is could you tell us a bit about yourself very briefly and your background?
I'm Alyson McGregor. I'm the director of Altogether Better. I started life in public health. Found it quite frustrating sometimes because most of the work was being led by national policy. Couldn't always see that it made a difference in terms of what happened to people in communities. It was often about messaging, trying to get people to do the things that the system wanted them to do. But that was a world that took me into the work that I'm in now. I have done lots of things in the past. I've worked for the voluntary sector, I've worked privately for a while, and I've now worked with Altogether Better. I've been with Altogether Better since 2008, and it's been the most enjoyable thing I have ever done. And people keep asking me when I'm going to retire, and I don't want to ever answer that question because I love what I do.
I know that feeling. Anyhow, Altogether Better is your organisation. Tell us, what is it? How is it structured? And what exactly is it?
Okay, so we are an NHS network organisation, which means that we are hosted by the NHS. We're hosted by South West Yorkshire Partnership Foundation Trust, which is a fantastic mental health trust that sits in West Yorkshire, but we work all around the country. We are currently working or have worked with around 25 CCGs all over England, and when we're lucky enough we work abroad. So we have not long ago been involved in a really sort of decent piece of work in Ontario that was around the Canadian government funding a pilot initiative to find out what would happen if they were to involve people in communities together with people who deliver services. So we work wherever we're invited to work.
Yeah, I saw you had a project in Ontario, which is really interesting. Let me ask you a bit about what you do. I mean, a lot of people talk about what's called social prescribing, where a GP, instead of prescribing medicine, prescribes social contact and activity. Is Altogether Better different to this, or is it trying to develop that particular idea and coordinate and support it?
Okay, so our story is that I suppose we start off by being the greatest fans of the NHS, and we think that the NHS is it's the jewel in the crown of what we do in this country, and we should be really proud of what we do. But it's under extreme pressure, and the reason that it's under such extreme pressure is that when it was set up, it was organised to treat infectious disease and to fix the things that were fixable. Our data tells us that when people present to general practice today, the things that they present with are not the things that can be easily fixed. So our data says that between 40 and 55% of people who come to a GP for a clinical consultation have a non-clinical need. So it might be that they're struggling to cope, manage and adapt with a long-term condition, with the things in life. It might be bereavement, might be loneliness, it might be a whole range of things. It might just be coping. They're the things that people struggle with. But general practice currently isn't organised in that way in order to make a response. So we typically, a reaction might be to push people away, to tell people that they're inappropriate attendances. What we want general practice to do is to invite people in and to find out what it is that people need, and then match them up to the things that will support their need. And we do that collaboratively. So we think that the social prescribing link workers are absolutely crucial. I'm a huge fan of social prescribing. I managed a social prescribing service 15 years ago. I'm a member of the National Steering Group. We for the development of a social prescribing workforce, but that workforce cannot meet the need that we've got. So what we need to do is to create an extended family of people who come together, who are health service workers, voluntary sector, people, local citizens, who come together to work out what matters.
Yeah, someone said that social prescribing really doesn't just do justice to what you do. They said it was partnership philosophy or syndicated well-being. Is that how you would describe it, and what would that mean?
I don't use that language, and what we have learned in this work is that language is everything. You know, language creates meaning, and we use language that hopefully will connect with everybody. So in collaborative working, when we work together, one of the things that makes it not work is that we use language that excludes people. So we really pay attention to language. I think social prescribing is the language of the health service, and it was I am part of the national network, and we put out a survey about 3 years ago and asked people what social prescribing meant. We got 47 different varieties back. So I think there's something about how we use language, and many people don't like it, but it was felt to be something that would help to take the work into general practice, to take a social dimension in, and it has done that, and we have seen some amazing changes. But I think that the language that we use to describe our work is language that I hope would be that people would use. And we did a really large piece of evaluation work in 30 GP practices, and we looked at what worked and what didn't work. And we worked with some linguistic analysts, and they helped us to understand how language either helped or hindered. So we worked really hard and pay attention to that.
Okay, so syndicated wellness is banned with the social.
Not my language.
No, okay. But I mean, you do collaborative work, and you've explained that everyone comes together. But in order that people can get a better idea of what you do, could you give us one example that would help us better understand it?
Okay, so we start off by finding either enthusiastic GP practices or enthusiastic primary care networks or whole systems who want to do something differently. And we support them, those people in the practices, to think about the context in which they're working, to actually take stock and think about what it is that we are here to do. We take the data that general practice has incredibly seriously. So general practice has the most robust database in the community of need. So they know lots of things about people, the things that people struggle with, the things that make life difficult, and typically they don't use that data. So we get them to look at their data and to consider why is it that people are presenting at general practice. So we're helping them to think about need, and then I guess in a nutshell what we're doing is we're then supporting them to marry up that need with offers of support, and the support might come from lots of different places, so that people might need public sector support, they might need paid for support, maybe from a social prescribing link worker, a specialist role, or a health coach, or somebody in a paid role. Or they may need support in the voluntary sector, to deal with a bereavement. They might need to talk to somebody who has some skills, some training that can help them to get through that. Or they might just need help from one another. They may need to just be connected. And there is another level of support, which is the kind of support that practice health champions, we invite people to volunteer their time with GP practice, might offer to people that's not part of those more formal offers, or it might be that they can just help one another. So what we try to do is we set up a small collaborative practice team. That team's analogous with a social MDT, and that team comes together. So it's a really diverse group of people. It could be a GP, a practice manager, a nurse, a receptionist, social prescribing link workers, really important, and that a person from the voluntary sector. And that team of people look at their data, try to understand why people are coming, and then they invite people. We help them to invite champions to become involved. So my language is not of recruitment. You don't recruit people to give you a gift. We're inviting people to come forward and give their time to work alongside us as peers, as partners, on the things that matter. So we invite people forward, and when they come forward, it's humbling. So one GP practice put out an invitation one Wednesday evening, and within 1 week, 600 people responded, which is staggering.
Well, I was going to ask you about the volunteers. You mentioned social prescribing link workers. You also mentioned champions. Are they the same or are they different?
A social prescribing link worker is a paid worker who is either employed within primary care, general practice, or possibly back within the voluntary community sector. And their role is to connect people up to offers of support, usually in the community, that will help them to deal with the more social aspects of health. Practice health champions are people like you and me who are invited by their practice, to come forward and gift their time to work alongside them, to work on the things that matter in that area, in that place. And so it's a voluntary role. We don't call the champions volunteers because people have a mindset about what a volunteer is. We know volunteers who have to be trained. If we were to have a fall on a mountain, you'd want a trained volunteer. This work, when we're working in general practice, you don't need to be trained to go on a walk with somebody. You don't need to be trained to have a chat with somebody. What we do is we tap into the skills that people have, into their qualities, into the things that they bring, and we don't try to formalize it. We don't try to professionalize it or make people into mini-me's. They're not an extension of the health service in that way. They're part of an extended family, and they're different to us. So they bring their skills, their offers, their gifts.
Yeah. I mean, your champions, though, can be and they can show a lot of initiative, can't they, and develop projects of their own. I noticed that, for example, in one case, champions came into the surgery and chatted to people. Partly, some of them had dementia before they saw the doctor. In another case, a teenager saw in a hospital that they didn't have a teenage room. They had toddlers rooms, but not teenage rooms. So she said about, putting pressure on for them to have one of those, which she got. Are champions innovative? Do you really depend on them to come up with the ideas?
It's about everybody. It's about what matters to both that collaborative practice team of folks in the practice and the champions, and they come together and they work out together what matters. But they also are led by the data, so they're informed by what the data says. But we do ask people what matters to them. So the first piece of work that we did in Canada in 2014, we asked people. We often do workshops with people, and we ask them what matters, both the health professionals, social care workers, and the champions, and they came up with the same thing. They said that we don't want people to die at home alone. And the reason that happened in that area was a very rural part of Canada. When older people lost their driving licenses, they lost everything. There was no public transport infrastructure, so they lost their friends' network, and ultimately they died at home alone. And I love that example because it's not about what we've been told are the priorities from the top. It was what matters in that place to those people. And they came up with so many different ideas to keep people connected, to avoid that happening. And that happens everywhere. So it might be that, in some areas, there's a larger number of older people. We did a lot of work in Barnet. In Barnet, I think Barnet has the most care homes in the country, so you're more likely to be working around those issues. In other areas it will be different. Often general practice want to work to support people who come most frequently. That's often an indicator that people's needs are not being met. So a general practice in Stockport looked at their data. The number one person on their list was a person called Florence. She's 86. She comes 3 times a week. She hasn't got people around her to support her, so she comes to general practice, but they would never send her away. But instead, they introduced her to Dave. Dave is one of the champions. He chatted to Florence, works out she likes to sing, so he meets her in the practice the following week, and he escorts her. They go together to the singing group in the precinct. He introduces her to 3 other people, and she doesn't come to the practice anymore other than to bring cakes for the girls on reception because she misses them. So for me, I think it's about what matters to people, and I think it matters not just to please general practice, because some people say, oh, this is all about general practice. It's about what matters to us together, the practice and the people in community.
So when you start a project, you say it's not just about general practice, but when you start a project, do you start it from the general practice, or can it start from an idea of a champion, or can it start from your assessment of need, like you just explained in Canada?
I think it works across all of those levels. It's not. It doesn't matter what the generator of that is. What matters is that the group are enthusiastic to do something about it together. So you have to use that energy. If people are not enthusiastic, it's going to struggle. So we did a large evaluation, a large-scale evaluation, and we found that the work had to be meaningful and it had to be fun, and not just for the champions who are gifted, but for the staff who are involved. So I think that was really, really useful learning. And we know that those practices who do this well will talk about finding the joy in work again, and the champions don't go, stay with. So the first practice we worked with is in Pudsey in Leeds in 2011. We worked with them probably for about 6 months. They're still going strong. They have more than 60 active practice health champions. That would not be continuing if it wasn't fun, if it wasn't meaningful, if people didn't feel that they were making a difference.
Okay, so when you do what you do, and you look for volunteers and so on, and you look for the need in the community, you use an interesting language. You talk about gifts that the community have. That sounds to me like a language of what's called ABCD, asset-based community development. Is that the sort of model that you follow?
I think it builds on what's important in asset-based community development. So it's about the resource and resourcefulness of people in communities, but it's also about the resource and resourcefulness of the people who deliver services. And I think asset-based community development is very much placed within the community, and it's fantastic. But I think there is so much work to be done that there is room for all of the ideas that we've got to coexist together. So it shouldn't be something that competes with. We think that, so if you think about using resource in a community and recognizing its gifts and its assets, how many practices truly recognize gifts and the assets that a receptionist holds? So we did a piece of research work to find out who had a better idea about patient compliance, the receptionist or was it the GP? And we found that the receptionists were more likely to be correct than the GP, because they were able to see from people's body language, from the demeanor when they left. They know those people are themselves with them, whether or not that person was more likely to be compliant. So why don't we tap into that incredible resource, into the receptionist who knows that Mr. Walker's gone downhill since his wife died, and do something about that before Mr. Walker's really poorly, and it's not too late.
In a way, it sounds like what you're developing is a sort of exchange, a skills exchange, a needs exchange, which is really interesting. And I was going to ask you how you got your volunteers, but you partly answered that. You said the doctor phoned up, or the surgery phoned up and got 600 volunteers all at once. But that's a hell of a job for you once you've got them, isn't it? How do you match them up? How do you fulfill their needs? I noticed that the NHS has a scheme to get volunteers over COVID-19, and a lot of them aren't used. So do you find you've got lots of volunteers and you're not able to match them immediately, and you've got a problem?
So our 600 was a bit of a lesson that we learned. The practice invites them through a text message, that lands in a mobile phone that says, we'd like you to invite you to work alongside us to make a difference to the people who live in wherever it is, and respond, and we handle that response. General practice doesn't have to do that. What we look for is work with around about 20 at a time. You can't be in relationship with 600 people. So when we got 600 people, that was because the text message went to everybody on the list. So now we send them out in small batches rather than to everybody. I think there was a feeling that people would not be generous, would not come forward in number, and they do. And I think that the response to NHS responders was a great example. People tell us that they're honoured to be asked, they want to give back. What this is doing is it's sort of trading on an existing relationship.
Okay, and it's not just GPs. Very often you said you work with other agencies. I noticed that you've got some examples of care homes where the manager of care homes gets in touch with you and they can do things. And it's organisations like that, not just the GP, isn't it?
What we did was we worked with a general practice who wanted to support people who lived in the care homes that they supported. So the collaborative group were made up of care home staff, local pharmacists, the GP practice, and then we used the fact that general practice was in relationship with people as a means to connect with people on the list. So they put an invitation out to the GP practice to people on their list and said, we'd like you to invite you to work with us and the local care homes that we work with, make a difference. And we didn't know whether many people would come forward. This was in a small town in the northeast called North Shields, and 186 people responded, which was unbelievably stunning. And they came forward, and the things they did made a huge difference. So it's how do we break down those sort of barriers between the institutional world of a care home and society? And I think we created a sort of semi-permeable membrane where people could go backwards and forwards. So the care home started to take residents out into schools. Schools started to come into the care home. Champions started to take their grandchildren along. We saw residents trying to move and kick a ball back to a 3-year-old who hadn't attempted to speak, hadn't attempted to move, were not keen to eat, actually re-entering the world again, because people need other people. So this is about trying to find a way of being. So it's not about systems and processes, it's about finding a way of being which is about valuing people, which is about seeing people as equals, which is about, I think it's about kindness, I think it's about compassion, and I think it's about enabling both health service providers, health and care providers, and people to be able to show that.
Despite all that, it is still a different way of delivering healthcare, isn't it? It's not the traditional way. And you've got, well, you probably have more now, but you say you have 130 GPs involved with you, but that's only a small minority of GPs. Is it an uphill struggle to get GPs involved in this, or do they just open their arms up and say, come in?
I think it's like everything else in life. You know, people have different preferences around the things that they're interested in, and there are many, many GP practices and GPs working out there who recognize that this would be really helpful. I think there's some fear around how do we create some space to be able to do this. So I think there's that. But what we have done is over the years have found ways to make this happen that actually reduces the impact on GP time, spreads the work between people, and it just simply becomes a way of being. I think with the growth of social prescribing link workers, we see that this work, collaborative practice, can provide a wraparound service to social prescribing link workers, so that, you know, that idea of an extended practice team. So if a link worker is working with a team of 10, 20 people who are gifting their time to do different things, when we can really increase the amount of support that we can give to local people. And I'm not talking about exploiting people in order to get work done. There are things clearly that are formal offers of support that need to be paid for. But then there are things that people can give their time, and we know that they want to do that. And we know that volunteering makes a huge difference for people. So for some people, it helps them to get into meaningful paid employment. So our data says that between 8 and 40% of people moved on from the work that they were doing with us into meaningful paid employment. So we have to keep on filling the pipeline. We know other places where people will say, I arrived that day and I left with 17 friends. So, you know, they'll have met 16 other champions in their group, and still today, you know, 4 years later, they are the best of friends. So people, it's reciprocal. It's about reciprocity. Everyone benefits.
The other thing about it is, I mean, we often say the health service is underfunded, but in a way you've got a model which says you can get more for less, which is a sort of business model. When you talk, I know about a business model. It's a model that releases resources in the health service and creates capacity. I mean, do they understand that? Do GPs and everyone understand that you can do more for less, but if you adopt a model like the one that you have?
I think they do, Francis. I think that what we have learned to do is to not just apply our community development principles to meet the needs of people in communities, but we've tried to do that in terms of meeting the needs of general practice. So we know that GPs are under pressure. We know that people are leaving the profession. We know that people want to retire early. We work with a practice manager, a fabulous woman called Jane Dawes. And when we first met her, she told me how many days it was before she retired. She said something like, and I've got 454 days to go. People are under extreme pressure, and what this work does is it helps to meet their needs. So there's a lovely little film of Jane on our website where she talks about finding the joy in work again. She says, I thought this was another good NHS idea, and she rolls her eyes, but she has got involved. It's making a difference. She's now meeting people's needs. She has transformed her practice along with the colleagues in her team and the champions, and they're just doing things differently. Last week, and they do things quickly. So last week, they heard about champions in another part of the country making face masks, and they put them into plastic envelopes and they hang them on a shoe tree, and people who come into the general practice can take one for free. Within 5 days, Jane had involved the champions in her practice in Blackmore Vale in Gillingham, and they had a mask tree, and people were taking masks within 5 days. This is about being able to be spontaneous, do things that are fun. When people see that, they behave differently when they come into general practice. So Jane talks about her complaints have gone down. She doesn't come downstairs to hear a complaint. She comes downstairs because an 8-year-old wants to say thank you for the books in the book bag that are free to take away, because the practice is saying to them, we hope that you will enjoy reading. They have changed the face of general practice.
But it's saving resources, yes, but the way you describe it then, it's about creating a new purpose for volunteers, a purpose for professional staff as well, and that gives them new life. And do you notice that?
Oh, absolutely. They're just completely inspired and motivated, and they want to share their stories. We've got practices talking to one another across the country, and for some it will be really important that it saves their time, so that GPs can actually put their children to bed on a night. That really matters. We don't want people to be burned out. We want them to be great GPs. Another practice in the Northwest, the GPs talk about now seeing 12 people in the morning session each instead of 15. And in the extra time that they have coffee together and they discuss difficult clinical cases. So that gives them more a sense of their value and worth, because that's what they're trained to do. So I think that we do see, if we can look at what GPs need, or the staff and practices need, if we meet everybody's need, we can create something that's really magical. And I think this is really not dissimilar to asset-based community development, but this is about seeing a general practice within a community, within the core of a community. So it's not the community and general practice. It's we are the community. We are together. We do this stuff together, and we know that it makes life better for everybody. And we talked about saving time. We did a deep dive into some data in the Northeast in a practice in Gateshead, and they have reduced their frequent attendance rates by 30%. That is staggering. A 30% reduction in frequent attenders. That means that GPs can put their children to bed on a night. It does mean that they can go home within normal working hours. It changes everything. So but people have to be patient. These things, this is happening in a human space. It's not about being more efficient. This is about being more connected. So what the work depends on is people who are willing to give some time to be together, to say thank you, to say hello, to be, willing to come down to take a compliment about the fact that somebody's just been in a ride in their tri-show and wanted to say thank you, rather than come down for a complaint. So there will always be work, but hopefully it'll be the right kind of work.
Well, you talk with great enthusiasm and great passion, and if you do that and suddenly all the GPs in the country said, this is great, we want to be involved, what would you do? I mean, you'd have a problem.
No, we wouldn't. We have a plan. So over the years, different leaders within primary care have said, how do we do this? And we keep coming up with a new plan and a new plan and a new plan. And I think it's a really big step for something to happen nationally to support a change as big as this. We hope that people will be brave. We hope that people will see, as a result of the emergency, the absolutely incredible generosity, the humbling generosity of people within community to come together. They can see how quickly communities can mobilize, can do the things that matter, can get food to people ahead of the system. They can see all of that. So how powerful can we be if we do it together, if we come together and we say what matters to us? So there's not that much that we can do that's really worth doing on our own. And we think that this work, we hope that people will come forward and do more.
Okay, so the last question is, if people wanted to know more about what you do or make contact, what do they do and where do they go?
The best thing to do would be to contact us on our website. So we are altogetherbetter.org.uk, and on the website you can find contact details. This work happens through conversation. We like to chat to people, we like to talk to people, we like to introduce them to people who are already doing this work. So we would just it always starts with a conversation. So we just really encourage people to chat to us. So it's basically altogetherbetter.org.uk.
Okay. All right. Well, thank you for doing that. As I said, you have great enthusiasm and passion, and obviously you enjoy the work you do, and all those people who work with you clearly enjoy it as well. And, you know, we have done stuff on social prescribing as well, but what you're doing, I think, is social prescribing plus, and that's really interesting. So thanks for doing it. And I'm sure people will go to your site, learn more about it, and people will be interested in what you do and want to see it replicated in their area. So thanks, Alyson, for doing this. It's been really great. You've done it. So thank you, and we'll end this interview now.
Thank you, Francis.